Hello, good morning once again and welcome to today's tutorials. Today we are going to look at the formation of urine under neuron physiology. So basically our beautiful kidneys over here will form the urine, and through the ureters it will send the urine into the urinary bladder where it stays temporarily, and when we get the urge to void, it comes through the urethra to the exterior. Now the urine produced is approximately 500 mils per day, and the normal urine output in 24 hours the volume is approximately 800 to 2000 milliliters per day, and this is specific to an individual who has taken about 2 liters of water per day. Now any amount of urine output which is less than 500 mils is considered oliguria, and to give us information about the state of the body and the state of the kidney function. And also any amount which is more than 2000 or 2500 mils milliliters per day is considered as polyuria, and a lot of disease states are associated with such a state. Now we also have this urine having a specific gravity of approximately 1.024, and the specific gravity of the urine also gives us information as to how the kidneys concentrate urine. In other words, it tells us the measure of the concentration of solute in the urine that has been produced. The normal range is between 1.005 to 1.030. So this figure here is an approximation. Now we have certain conditions which may increase the specific urine gravity, and others which may also decrease the specific urine gravity. So we may have a high urine specific gravity in states such as volume loss. That is when you lose a lot of fluid through vomiting, diarrhea, sometimes also when you get so much dehydrated, and in fevers you may have a very high urine specific gravity, and sometimes also in some heart failures, and also in shock. People with the syndrome of inappropriate antidiuretic will also experience high specific urine gravity. Now, a low specific urine gravity may also be seen in patients with conditions such as diabetes insipidus, renal failure, glomerulonephritis, or even pyelonephritis. This urine produced must also be clear, and it should be amber in color, with a pH of 5 to 6. Basically, this pH tells us about the acidity or the alkalinity of the urine which we have produced. And if the urine is so acidic, it gives us information about the state of the kidneys and the entire body. Likewise, if it is alkaline in nature. And so we may have a high acidic urine when a patient is acidotic, in patients with uncontrolled diabetes, also in diarrhea, when also you have starved yourself very long time, and when you also get dehydrated, you have a very high urine or acidic pH of the urine. And also in patients with respiratory disease, whereby carbon dioxide is retained and it combines with water to form the carbonic acid, which will cause acidosis, or which may lead to the development of acidosis. A high alkaline urine may also occur in some urinary tract infections, in pyloric obstructions, and also in some intoxication of drugs such as the salicylates. You may also get a high alkaline state, and also in some chronic renal failure. Also in respiratory diseases, we may also have a high alkaline urine. And this may be involved in a hyperventilation when we take out a lot of the carbon dioxide from the body, and so we become alkalotic. Now this is the simple introduction to the physiology. But what really goes into the formation of urine? Basically, we have three main stages in the formation of urine. The first one being the glomerular filtration. The second one is the selective reabsorption. Then finally we have the tubular secretion, after which we excrete the urine from our body. So starting from filtration, one thing we must know is that the blood will enter the glomerular capsule through the afferent arteriole. Now, the cardiac output is approximately 5 liters. And the blood flow to the kidneys in each minute is also approximately 20 to 25% of the entire cardiac output, which is about 1 liter per minute. Now, out of this, we have 40% of it being formed cells, and 60% of it, which is approximately 600 mL, being the plasma. Now, through the process of filtration in the Bowman's capsule, approximately 20% of the plasma flow is filtered through the glomerulus, and that will be around 120 mL per minute, and this will give us our glomerular filtration rate. Now, the remaining 80% passes through the efferent arteriole over here. Now, during the filtration process, one thing we must note is that certain substances which are needed by our body are lost through the filtrate. Also, certain substances which we do not need in our body also move along from the Bowman's capsule through to the proximal tubule and moves along the entire length of the tubule. And so through the process of reabsorption and secretion at different parts of the tubule, the 120 mL of filtrate which we formed is processed as it passes through the tubule, and at the end of the day we have fluid being excreted out here as urine. Now, still I want to stress on the things which are filtered. Basically, we have the water, the sodium, potassium, bicarbonate, glucose, amino acid, creatinine, as well as urine are all filtered in the glomerulus. Now, with reabsorption, we find out that it occurs along the entire length of the tubule, and we basically reabsorb water, sodium, chloride, potassium, amino acid, glucose, and also bicarbonate. So at the proximal tubule, we realize that is the major reabsorptive segment of the nephron, and it also accounts for approximately 2/3 of all the filtered water, sodium, as well as chloride. We also have in the proximal convoluted tubule, majority of critical organ solids such as the glucose and amino acids all being reabsorbed at the proximal convoluted tubule. And finally, in this segment, we realize that it also plays a major role in the acid base balance, as it is involved in the reabsorption of bicarbonate as well as the secretion of organic solids. Now, sodium is basically transported at the proximal convoluted tubule through the sodium potassium ATPase, and we have it being moved across the membrane with a specific sodium potassium symporter. We also have other organic solids and phosphates also being reabsorbed, including the glucose and amino acids. And as I've talked about earlier on, we have water also being reabsorbed at the tight junction of the proximal tubule. And this is because that place is highly permeable to water, and so water reabsorption will follow all the other solids, especially sodium. through osmosis. And as I've been saying, water and sodium are like husband and wife, whereby the sodium is the husband and the water is the wife. Wherever the sodium goes, this faithful wife, which is the water, follows it. So it is important to also point out that because water is reabsorbed with sodium, the effective concentration of sodium within the tubular fluid does not decline, even though a large amount of both molecules are reabsorbed. Still, at the proximal convoluted tubule, we realize chloride is also largely, not being transported at the early proximal tubule, but at the late proximal tubule, we have large or substantial amount of chloride being reabsorbed, especially at the tight junction. Bicarbonate is also reabsorbed at the proximal convoluted tubule. And calcium is also reabsorbed, and the proximal convoluted tubule is responsible for about 67% of the entire filtration of calcium. Now let's quickly move to the thin descending loop of Henle over here. This thin loop of Henle, and this segment of the nephron works, in different ways, in the transport of water and solid. Because over here we have the thin descending, and over here we have the thin ascending loop of Henle. They play different roles, which we shall see very soon. This is because the thin descending loop of Henle is highly permeable to water and solid, and it's approximately responsible for almost 20% of the water which is being reabsorbed. But the thin ascending loop of Henle is nearly impermeable to both water as well as to both solids, and so it does not contribute to the reabsorption of these substances. Now let's move on to the thick ascending loop of Henle, which is this segment over here. Now this is a major resorptive segment of the nephron, and basically it accounts for reabsorption of a quarter of the entire load of sodium, chloride, as well as potassium. Basically, transport is characterized by the sodium, chloride, and potassium symporter, which we find over here, and also it is aided by the sodium potassium ATPase, which is also over here. It is also important to note that at this side we also reabsorb things such as magnesium and calcium ions as well. Now, an important thing to note when it comes to the thick ascending loop of Henle is that the tight junction of this segment, this whole segment, is virtually impermeable to water, and so we realize that large amount of solids reabsorption that occur in the absence of water reabsorption takes place over here, and so the tubular fluid gradually gets diluted because water is not being reabsorbed. However, solids are being reabsorbed, and so the tubular fluid gradually gets diluted as it moves along the entire length of the thick ascending loop. And this is the main reason why sometimes we refer to this segment as the diluting segment of the nephron. Now let's move on to the distal convoluted tubule. So basically we have the early distal convoluted tubule and the late distal convoluted tubule. So this segment of the nephron is also responsible for roughly 5% of the filtered sodium which occurs through the luminal sodium symporter, as you can find over here, and reabsorption is aided by the sodium potassium ATPase, which you can also find over here. And this segment of the tubule is also impermeable to water, and thus the tubular fluid becomes further diluted, since solutes are being reabsorbed but fluid is not being reabsorbed. So we have dilution of dilution of the filtrate. Now the sodium as well as the chloride symporter is also plays an important role over here, since it's the target of a lot of thiazide diuretics, which we shall see very soon. And also the early distal tubule is responsible for around 8% of the filtered calcium which takes place in the lumen, and this is also aided by the calcium ATPase. Another important thing we need to know about the distal accumulated tubule is that it is the major regulating segment of calcium, its calcium resorptive capacity is also regulated by the parathyroid hormone, which we must note. Now, getting to the late distal accumulated tubule, it is responsible, or it represents the final segment of the nephron, including the collecting duct. They form the final segment of the nephron, and so at this stage, majority of the solute and water have been reabsorbed, and the late distal tubule and collecting ducts are only responsible for a small fraction of the total resorption. And we also find out that modulation of sodium, water, chloride, and potassium resorption all occur in the late distal convoluted tubule, as well as the collecting duct. And also, in addition, this segment is a major contributor to hydrogen excretion, and so it plays an important role in the acid base homeostasis. Now, more on the collecting duct of the nephron, we find that there are two main cells in this segment of the nephron. We have the principal cells and the intercalated cells. The principal cells are involved in water and sodium reabsorption, but they secrete potassium. Whereas we have the intercalated cells, which are involved in potassium resorption and hydrogen reabsorption over there. So finally, we also need to note that the epithelium of this segment over here is also impermeable, and that displays very little in the way of the paracellular transport of water and solids. Now, whatever we have formed over here, or whatever has taken place over here, the end is the excretion of the urine. The end is the excretion of the urine, and basically we excrete water, sodium, potassium, urea, as well as bicarbonate and creatinine, including the waters I've mentioned earlier on. One thing I want us to note over here is that creatinine is not reabsorbed along the nephron, and this is why its concentration is used as a marker of glomerular filtration, so that if the level of creatinine in your blood begins to rise, it may indicate a problem with filtration in the glomerulus. And another important thing I want us to note over here is that two main hormones are involved with the excretion of water over here. These are the aldosterone, which forms part of the renin aldosterone or renin angiotensin aldosterone system, And basically what it do is it acts on the distal tubule and increase the rate of water reabsorption. The second hormone is the antidiuretic hormone, which is the ADH over here, and this is released from the posterior pituitary, and it causes more water to be reabsorbed by the collecting duct. Now, both these hormones, act in states when we are dehydrated and when the body needs to retain a lot of water. So basically, this is the summary or the sum of the formation of urine as we have. Thank you very much for your attention, and please, I will encourage you, if you've not subscribed to this channel, please do subscribe to help us develop and also make more videos. Thank you very much for your time. Bye bye.